Okay, well, thanks everyone for joining us today. I just want to make a few announcements before we get started and look at the slide. I sent out an email, prior email, just asking folks again about the COVID-19 impact on your research effort. I think most folks said that it wasn't to the degree where it's your protected time. I just need to know that. So if you can just actively respond back with that, that would be great. Also, we'll be sending, of course, after this session, a feedback survey. There's a couple other surveys that I'd like to make sure that we get a better response rate. I mean, hopefully everybody. So we'll send links to that. If you're not sure, because these are anonymized, you can just fill it out. It's fine if you do that. I wanted to let folks know too, we do have an ARC progress report coming up in July. So there's quite a bit of information that I need for that purpose. So I will be sending out probably within the next couple of weeks, a survey asking you for a variety of different types of information. So if you can be sure to be responsive to that, I would appreciate it. Our next work in progress meeting session is on June 1st, and Ann Kazak from Nemours is going to be presenting. We're going to treat it more like a learning session than a WIP, just because of the scheduling issues. So just be aware of that, and anything we need you to read or prepare in advance, I'll share that. And then lastly, I just want to let you know about the next quarterly ARC Learning Health System Leaders Series. That'll be on June 17th. I believe that's on a Wednesday for an hour in the middle of the day. And Lisa Simpson, the CEO and president of Academy Health, will be joining and talking about translating results and data into policy and practice. So of course, that's of high interest to us. So without further ado, I want to turn it over and just introduce our speaker for today, Renad Bedas from the University of Pennsylvania. She is an associate professor of psychiatry and medical ethics and health policy at the University of Pennsylvania School of Medicine. She is the founder and director of the Penn Implementation Science Center, and so we're really excited for her to share. Her work is focused on advancing methods to promote uptake of evidence-based practice into routine care. So, really it's foundational to what, we're trying to address and learn in learning health system science. So with that, I'll turn it over to Renad.
Thanks so much for having me. I'm hoping that my 4- and 6-year-old will not make a guest appearance, but if they do, I thank you in advance for your patience. And I also see a little baby, which is really exciting. So congratulations on that beautiful little guy or girl. And I'm looking forward to getting to know you all. I see some familiar faces, some folks I've known for a long time, and then some new faces. So I'm gonna try to figure out, you guys can see my screen, yes? Yep, cool, all right. GoToMeeting is like only one of these platforms I haven't used very much, so apologies for the, okay. Can you see that? Yes?
Yeah, I think there's just a little lag.
Okay. Also, I'm realizing I can't see your faces if I do this, which I don't like because I like seeing your faces. So maybe what I'll do is make this like so. No, I can't see your faces again. Okay, I'm just gonna live with not being able to see your faces for now. Are we good? Does everyone see the title slide?
Yes.
Okay, all right, thanks guys. So I really wanna make this as interactive as I can. Obviously, the circumstances for all of us we're coping with lots of different things going on in the background, myself included. I'm gonna try to toggle between this screen and your faces whenever I go to a discussion point in this talk, because I really don't want this to be me just kind of talking for the next hour and a half, and I know you guys don't want that either. It's wonderful to be here. And I know that actually 2 of you are at Nemours, at least 2 of you, and I was there last year, and so there was you've seen parts of this talk before. However, my personal view on implementation science is that it's helpful to kind of hear these concepts several times because they are a little bit different than the way that we typically think about doing biomedical research. So for those of you all who I have talked with before about these concepts, I may ask you to weigh in if other people aren't speaking, just because I do want to make sure this is interactive. So I'm Renad. Hi, I'm from Penn. For those of you all who are on the Twitter, I use Twitter a lot to disseminate information about implementation science. We have a super robust community on there, and I think that Twitter can be a really useful way to stay on top of the literature. So if you're interested in InSci and you want to kind of get up-to-date stuff pushed your way, feel free to follow me, and I will look forward to talking to you on Twitter. Sorry guys, I'm trying to find a way to look at your faces and also do this slideshow. So
Renat, do you want to send to me or Ingrid, and then we can drive it, and maybe
that might be better, because it's really going to bum me out if I can't see you guys.
Okay, why don't we?
Really, okay, sorry. I really don't like to talk into the ether without being able to see people's faces.
Go ahead and send it to me.
Let me. Okay. Do you want to take me off presenter mode?
Sure.
Because if I know you guys are all watching me trying to figure out how to email it, I'm sure it won't work. Okay. All right. Okay. I'm wondering if it's going to be too big to, we'll find out. I'm going to send it from my Gmail.
Okay.
Because it's too big to send from my Penn email. Okay, I'm uploading. I think my computer is moving particularly slowly given GoToMeeting. So I'm going to pivot while it's uploading and being sent. Part of the presentation was to get to know a little bit about you all. So why don't we do that while the email is sending. I'd love to know a little bit more about each of you, your names, your institution, and one thing about implementation science that you hope to have answered by the end of our discussion today. I will ask you, is there like do you have a list, Jeannie, of folks, and can you just go down the list to ask folks to introduce themselves?
Sure. Well, why don't we start with Corinna? I'm just looking at people in the gallery.
Sure. So I am Corinna Schultz. I am a pediatric hemonc doc down here at Nemours. And what else did you want to know? Something that we wanted to learn. I am thinking about a project that I am still conceptualizing that I think sort of borders on implementation science. And so I am very excited for this talk, really to help me sort of frame and start thinking about this project and where I need to go and start thinking about.
Corinna, in like one sentence, can you just tell me like the gist of the project so I can have that in the back of my mind as I'm talking?
Yeah, sure. So this is actually quite different than my PEDSnet project, but I'm really interested in how we take information in the newborn screen, specifically as it relates to people's caring for inherited hemoglobinopathies. and what happens to that information and how does it filter to the family and then into adulthood. And so right now I'm doing a small pilot study where I'm looking at just the documentation within the medical record and seeing that it's quite terrible. And so really, how do we increase that documentation and sort of get people, one, get people's buy-in that it's important to do, and then two, how do you sort of nudge people to actually documenting it and having conversations with families so that it can carry across the medical system.
Nice. That sounds fascinating. And what the project I'll be talking about is leading us to a nudge study in the EHR. So hopefully that'll be relevant to you and the work that you're doing. Thank you.
Yeah.
Rita?
Hi there. I'm Theda Ahn. I'm a pulmonologist at Seattle Children's, and I work primarily with cystic fibrosis patients, but have a general interest in a lot of chronic pulmonary conditions. I think I love implementation science and like what Corinna said in terms of how there's the theories of behavioral change out there. I think that I've struggled a lot with all the different kinds of theories out there, and even with consolidated frameworks on top of consolidated frameworks, trying to put it all into place where how you organize that kind of information as a whole. And I guess it's really hard for me to figure out what's the best one I should use for the study as the theoretical framework to drive that implementation, I think. And that's where I have a lot of difficulty navigating. So I would love your input on that.
Sure. Make sure to flag that when we get to the framework section. And you are not alone. Basically, everybody who comes to the field of implementation science struggles, given how many frameworks we have. The last count, I think, was over 150. So it's just really hard to know what to use. Although I think once you kind of settle into a groove, there's probably like a key set that I always go back to. But I feel your pain.
Katie?
I am Katie Shodis. I'm at Children's Hospital Philadelphia, and I work in the ICU primarily, but also I'm trained in infectious diseases and do some work related to antibiotic stewardship. Theda sort of took my thing I hope to learn, which is also a little bit more about how to pick a framework given all of the frameworks that are out there. But I'm also very interested in the hybrid designs as well, since a lot of the projects that I've worked on in the past have been sort of implementation of somewhat evidence-based strategies, but a lot of what we do in pediatrics is of course extrapolated from adults, and sometimes the quality of that evidence is variable in terms of its strength, and sometimes not based on like randomized trial data and things like that. So I'm very interested in especially that earlier kind of hybrid design, that the type 1 design, in which there's kind of some overlap between effectiveness and implementation science, because I think that would fit nicely with a lot of the work that I've been working on for both the PEDSnet project and for other projects that I've pursued.
Awesome. Anita, do you want to go next? I can see your names now, so.
Can you guys hear me?
Yep.
Okay, so I'm Anita Shaw. I'm currently a pediatric hospitalist at Cincinnati Children's. So I think in line with the previous comments, I think just filtering through all the information we've gotten, I've chosen a framework on health equity. My focus has been on health disparities in the hospitalized setting and how we can better screen and intervene on them. So especially in light of like COVID-19, thinking about how do we adapt quickly to shifting to address this, but then also more broadly with the health equity framework that I landed on, it sounds wonderful in theory, but what does it actually look like to operationalize and share that work or that content framework to staff that it probably doesn't mean as much to in that conceptual framework, but helps potentially to help get buy-in from those stakeholders.
Sure, yeah. I feel like the health equity intersection with implementation science is like a wide open area. There's some really great investigators doing some, you know, paradigm shifting work in the space, but it's a really good area to be thinking about. And clearly with COVID-19, everything is amplified now. So I'm really glad to hear that you're doing work at that intersection. It's a really important one. Stephanie and baby.
Hi, I'm Stephanie Bork. I'm a neonatologist at Children's Hospital of Colorado and the University of Colorado. And this is Owen. He's 3.5 weeks old. And I am excited really just to hear from you as a leader in the field. I feel like just learning about lessons learned and maybe advice you could give to us as junior investigators, sort of embarking on, you know, different projects that might use implementation science is what I'm hoping to learn today.
I think Owen may be the youngest implementation science student that I've had thus far, so I love it.
He might be the smallest too. He just topped 5 pounds this weekend, so he is a tiny little baby.
Oh my goodness.
We are rocking the SGA world.
Amazing. Well, I can't believe you're sitting upright right now. So amazing. And I understand if you fall asleep. I can't say I would have been awake when my kids were 3.5 weeks. Erica.
Hey, Renat. So Renat and I went to grad school together. We've known each other for like 15 years. So I'm a pediatric psychologist at Nemours in the Cardiac Center. I am most interested in learning about how you can incorporate aspects of implementation science, even when there is not an existing efficacious intervention for the patient population that I'm working with. And my focus is on psychosocial interventions that are family-based to prevent post-traumatic stress. And so right now we don't have a lot of evidence for those interventions with this population. So what can we do, if anything, of implementation science?
Awesome. Thanks, Erica. Chuck?
Hey, so I'm Chuck Barnell. I'm a nephrologist at Cincinnati Children's with a focus on taking care of kidney transplant patients. So if you guys think in pediatrics, there's a lack of evidence for things, we are really winging it on the transplant side, mostly due to numbers like everything else. But my main research focuses on medication adherence for immunosuppressive medications and different strategies to identify it prior to poor clinical outcomes and what we can do to improve these clinical outcomes for our patient population. And so the thing I'm looking forward to learning is we're currently trying to spread some work we've locally been doing since 2015 throughout a big learning health system. And so that involves a lot of implementation. And my struggle as one of the people who's helping to lead this project is the more I read about implementation, I've just been looking for the one paper that's going to tell me what to do. You know, like if you do these things, then it'll work really well, but it still feels very academic. And granted, I've only been reading about it for the last year or so, so I have a lot more to learn. But it just feels, I don't know. I'm trying to figure out how to take a lot of what I read and make it into practical, actionable information.
Sure.
So.
Sure. Yeah, that's the step that we've under prioritized in the field, but it's a really important step. And I'm sorry to say there's not one paper that I can direct you to that will answer your question, but there's certainly probably a suite of papers that might help elucidate that I'm sure you've already read, but I'm happy to chat more about that as we dig into the meat. Amy.
Hey, Fernand. I'm Amy Hildenbrand. I'm a psychologist at Nemours. We've had the good luck of meeting a few times, or I've had the good luck of hearing you speak a few times and meeting with you once. So a lot of my work focuses on understanding kind of uptake of psychosocial interventions, particularly in pediatric hematology oncology. One thing I'm really curious to hear more about today is these hybrid designs, and more specifically, kind of when you're at the point where you've done a lot of formative work and you're ready to design a hybrid trial, how do you prioritize or systematically plan out which implementation strategies you want to start trialing first? Because I think sometimes you're trying to balance resources and stakeholder input and excitement, which doesn't always line up with maybe what the global evidence says about what should work.
Sure.
So kind of trying to figure out how do you then start to design which implementation strategies to start trialing first would be really helpful.
Yeah, we'll definitely touch on that. Although that's like a whole I don't know, that could be like a 10-hour conversation that we're also still, I think, as a field trying to figure out. You know, a lot of these topics are topics that we're going to be really digging into. We're just launching an advanced implementation science course at Penn because increasingly there's folks who want to make this kind of their thing. And, you know, these are all things, you know, in an hour talk you can touch on, but it really require like a whole like class session to talk about like how do you design implementation strategies while including stakeholder input and context and what's pragmatic. And, you know, so I'll try to touch on all this stuff a little bit, and I'm happy to share additional papers that you could look at or have one-on-one meetings afterwards if that's helpful, because I won't be able to go deep on anything really given the time that we have, or maybe I'll come back. But anyway, that's wonderful. Is there anybody else who's not on camera, or anyone else who didn't introduce themselves?
I think Melissa, I think she's on the line. I don't know if she had to step away. Melissa, are you on the line? Okay, she might have stepped out for a moment. I think that's all our scholars.
Cool. And did you get the PowerPoint?
I did. So let's see if we can get this to work.
Great.
How's it?
My computer is making a really loud noise, like it's getting ready to take off. So I'm hoping that it's not going to explode over the course of our time together.
Do you guys see the PowerPoint title slide?
Yeah.
Yep. Okay. Next slide. Great. We already talked about that. Cool. So, so we can scooch past here too. I want to make up some lost time. You can go to the next slide. So we already did that, the tell me about you, and that's wonderful. I'm just going to ask that you give me a moment so I can tell you a little bit about me and how I came to be interested in this topic, because I think it's relevant, and I think it's particularly relevant given that everybody on this phone call is clinically trained and is bringing their clinical expertise to the set of questions that might be informed by implementation science. So next slide. So, so my path to implementation science really came from this clinical observation that I and Erica and others made that were just not ignorable observations. And if you had told me when I started graduate school in 2005 that I was going to be an implementation scientist, I would have looked at you super funny and been like, "What are you talking about? What is that?" I'm going to be a clinical psychologist because that's what my training is in, and I am a clinical psychologist, but really this clinical observation, I think it just speaks to the power of what we see as clinicians, and how important it is to use those observations to inform the research that we do to make it really actionable, and to motivate us to do work that really has impact. And that's what's really drawn me to implementation science. Next slide. So I won't belabor this point since we've got some psychologists on the line, and I'm sure you guys have heard from them about different treatments, psychosocial treatments. But Erica and I both trained at the Child and Adolescent Anxiety Disorders Clinic. Erica, that seems like a lifetime ago, but it certainly did happen. And suffice it to say, what's pictured here is exposure therapy. Cognitive behavioral therapy is really the leading intervention, sorry, I'm just closing my window, for the treatment of childhood anxiety disorders. And Eric and I provided clinical services in a basement to kids with anxiety disorders all week long, and we did a lot of exposure therapy as clinicians in the clinic during that time. Next slide. And I'm going to share the story of a client who I'm going to call Emma, that really represents the clinical observations that many of us were making as clinicians in the anxiety disorders clinic. So frequently we would kind of see this pattern happening over and over, where a child would come to see us and they had seen a number of providers in the community for their anxiety, and they hadn't received an evidence-based practice and they hadn't improved. And so Emma was a 16-year-old female who came to see me after the same kind of pattern that I was describing. And what's notable is that if you've gone to seek treatment for something that's hard for you and you don't get better, you become hopeless and think that nothing will ever change. And this was a kiddo who had stopped going to school, was having severe panic attacks, and wasn't doing anything that she enjoyed. And so you can see pictured here an illustration of what she was able to do after she received an adequate dosage of cognitive behavioral therapy. And so you can see that she returned to school. She could sing in the choir again. She went to the dentist, took her SATs. So she was able to kind of do the things that made her life worth living. And that doesn't mean her anxiety went away. It just meant that she learned to tolerate her distress and do the things that were important to her. Next slide. So after seeing that a number of times, that pattern, I started to wonder, why do I want to spend my time developing and testing new treatments for pediatric anxiety when we really know that we have treatments that work? And instead of that, I'm really going to pivot my career and start thinking about how to implement what we know works in community settings. And implementation science was just kind of gathering steam right when I was starting graduate school. So the inaugural journal was came out in 2006. The first conference at NIH, which I was lucky enough to go to, there were 80 people there, was in 2007. The last one had over 1,400 attendees. So, you know, the field has really skyrocketed since then. But it felt to me to be kind of the right solution to these observations that we were making as clinicians. Next slide, please. And certainly this observation is not idiosyncratic to my experience or the field of psychosocial treatments, even more broadly. It really reflects a broader field-wide issue. Next slide. Thank you. This is what makes it hard when you have a lot of animations in your PowerPoints and you're not controlling them. So apologies for the staccato here. But you know, we see headlines like this, you know, just in the example of pediatric mental health. Young people's mental health is a worsening crisis. Certainly I could have included some headlines from the past few weeks around COVID and mental health. Next slide. So you might ask, okay, so we know that mental health is an issue. It's increasingly even more of an issue. Do we have treatments that work? And the answer to that is resoundingly yes. So if we go back to 2016, we know that there have been almost 700 RCTs done for common psychiatric disorders for youth populations. We have hundreds of evidence-based practices. But if you go and look in the community at what clinicians are doing, usually what we see is that usual care does not reflect those evidence-based practices and that the effect sizes are quite attenuated. And I've done a lot of work in the city of Philadelphia looking at what types of evidence-based practices community clinicians use. And despite, you know, a lot of investment by the city of Philadelphia, Department of Behavioral Health, there's still room to grow in terms of what usual care looks like and how much evidence-based practice is well represented. And so this is still kind of a steep hill for us to climb in the kind of pediatric psychosocial treatment world. Next slide, please. But as I mentioned before, the truth is there's research to practice gaps all around us. So this is the first documented research to practice gap. It took 200 years for citrus to be routinely placed in ships to prevent scurvy. And so we're doing better today than we were doing at that time. Currently, the estimate for research to practice gap is about 17 years for 14% of research to make its way into practice. If you're thinking about things from an impact perspective, which is what I spend a lot of time trying to do, that feels like too long, in my opinion, and wasteful, that we're pouring so much money into discovery and that much of it is not actually making its way to the people who need it. Next slide. So I think, do you mind, can you actually launch the slideshow? I think it's losing some of the stuff. Is that possible? It's not the end of the world if you can't.
Maybe it lost some.
Can you go to slideshow current launch from the current slide.
Let's see.
Yeah, thanks. That's perfect.
Okay.
You got it. Great. So there's some things we do too much of, right? And so I know, Katie, you're interested in antibiotic stewardship. That's an example of something that we tend to overuse in line with evidence-based guidelines. We also know that in medicine that there's underuse, and I'll be talking specifically about a program of research that I've been doing for the past couple of years with regard to firearm safety promotion in pediatric primary care. That's an example of an evidence-based guideline that is vastly underused in clinical practice. So those are just two examples. I'd love to hear from you all, maybe 2 or 3 people. What are some things that are underused in your areas, or maybe elaborate a little bit more? For example, I know Erica was talking about psychosocial treatments for PTSD in pediatric cardiac patients, but examples like that, the things that kind of keep you up at night in terms of research to practice gaps that you're not seeing, and maybe even elaborate why you think that's the case, because that's certainly going to play into what implementation strategies we pick. So since you all kind of introduced areas, most of you covered a topic, but like maybe why not? Why do you think antibiotic stewardship isn't where it needs to be, or psychosocial treatment, or, give me maybe 2 people, give me a little bit more about your areas and why you think there's a research to practice gap.
I got one if people want to hear this. So I think people in general know that high blood pressure is bad and that we should treat it. And there's a lot of data that says why you should treat it. And in children, the benchmarks for what is and is not high blood pressure is based on measurement techniques, which is a 7-step process, because that's what they did for the NHANES study. And so people, the majority of the time, don't even measure blood pressure correctly in children. So the fact that we are appropriately measuring and treating blood pressure right, like 40% of the time for hypertensive general children, like not surprising because of how complicated it is, I guess, to even get the measurement in the first place. So how can we recognize and treat it if we're not even measuring it the right way? So.
Right. Yeah, Chuck, that's a great example. And, that kind of assessment time point dictates the cascade of events that comes after. And when I hear you talk, I'm hearing that the intervention characteristics, so if I was drawing from an implementation science framework like the CFIR, and in this case, the intervention is actually the process, the measurement, BP measurement, makes it is not pragmatic and it's difficult to deploy. And so, if I were thinking about, various ways to address that, just based on the little nugget you gave me, while understanding that I've never measured BP and I don't know how one begins to do it in a child, would be to try to simplify that process, for example, because we know that highly complicated procedures, particularly those that are part of a cascade, make it really difficult for people to implement properly. So that's a great example. Thanks. Anybody else have an example that they want to share and why they think that's the case?
I can share one. So in neonatology, we know that for most babies, delayed cord clamping is of benefit, and it has taken a long time to roll that out to our probably highest risk preterm population. And I think at least locally and in talking with other neonatologists, I think a lot of it is that it involves more than just our own subspecialty. It involves the OBGYNs, and getting consistent sort of buy-in from that group has been challenging. But the needle is starting to move, and we're seeing it in the more high-risk populations that are likely to benefit.
Yeah, that's a great example. And it's true that whenever there's multiple clinicians or providers involved in the delivery of care, that, sometimes one group might be more likely to adhere to the evidence-based guidelines where another might be less. I've been working with a team of reproductive endocrinologists who are trying to increase adherence to PCOS care. And so in their case, the OB-GYN docs are following the guidelines, and it's less likely in, a more kind of internal medicine, family medicine situation. So some of it is about specialization and knowledge and you know, skills, and getting that cross-discipline communication can be really challenging. So that's a great example of drawing from the individuals involved ring of the consolidated framework for implementation research. So when we get to that visual, you'll see what I mean, but I think you guys may have skimmed the paper in advance of this, so you kind of know what I'm talking about. Awesome. Anything else that people want to share? Okay, let's keep going. Next slide. I think there's going to be some animation, so you just click through it, keep going. Yep, we just did that. So you can go to, yep. And when you guys see that hand mark, that'll be a spot where I'm going to ask you to kind of weigh in. So you're going to keep seeing that over and over again. So just to briefly define what implementation science is, this is kind of what I tell people out on the street or at a party. We don't go to parties anymore, but on the phone, on Zoom, when they ask me what I do, it's about making sure that people are getting the things that work in the community. And really for me, it's about moving the needle in health and making sure that our discoveries are having an impact on the populations of interest. Next, you can just press the space bar. I wanted to also include the textbook definition, should anyone feel that that's important. I'm not going to belabor this point, but again, it's really about the scientific study of methods around promoting implementation. And I want to just quickly jump to Erica's question about kind of practical applications. I think there's so many ways that these concepts can be applied practically that don't necessarily require that you have like a tried and true evidence-based practice. But I kind of think about that more as like in some situations as like implementation practice. That's a question I get a lot. And interestingly, we have a really widening gap between implementation science and implementation practice, which is troubling. And a lot of the folks who are kind of doing this in the real world and practice settings are kind of saying, hey, you guys are doing the same thing that the treatment developers did. You know, 50 years ago. So like, and I think Chuck was saying like, it seems really academic and abstract. So I'm gonna try at the end to kind of loop it back all together. And as we think about practical applications, I think there's two ways you can apply. One is like, okay, I'm somebody in a clinic and I wanna take what I've learned from implementation science and apply it here. And then there's also, hey, I'm a researcher. I have something that's not an EBP, but I want to design for dissemination and implementation and draw from those concepts. And so those are two ways in which you can think about applying, you know, these concepts that aren't kind of straight up IMPSI that would get funded by the, you know, the dissemination, implementation, research, and health study section, which has a very specific definition of what implementation science is. Next slide. So I do think it's helpful to outline up front what the assumptions and foci are for implementation science because they are quite different from, you know, most biomedical research. So the first thing, just click the space bar because this has some animation. So I'm just going to say next slide, but it's not actually the next slide. Implementation science is about clinician, and I'm putting clinician in parentheses because clinician could be a lay health healthcare provider. It could be a physician. It could be a nurse. It could be lots of different things. But I'm just going to use clinician for ease of terminology. But it's about their behavior change within organizational constraints, not the patient outcomes. And that's super different from what we typically see in effectiveness studies. Now, that being said, there are these hybrid designs that you guys read about and are really interested in. In that case, we are interested also in patient outcomes. But at its core, implementation science is kind of interested in, once we know we have something that works, then what? Next slide. We don't see context as a problem. So I remember, you know, being with Erica early on in grad school, we were part of multi-site RCTs. And if there were differences in the site, you should, you know, the faces of the PIs were, they said it all, you know, that was not something that people wanted to see. They wanted to control for the differences in the sites, and they didn't want to have contextual variation. For us, and I think really that's one of the hallmarks of implementation science, we like understanding that contextual variation and we don't control it away. We really spend a lot of time using mixed methods to try to understand it because we think that that's really important to understand implementation success, and what strategies you might use, Amy, should really be targeted to the context that you're working within. Next slide. So there does need to be an evidence-based thing that you're trying to implement. And so that's particularly if you're going to try to get, a K or an R01 from DIRH or the NIH study section, you want to be able to say this is evidence-based. Now, there's always strategy in how you talk about that, and each person's field is a little bit different. So in psychosocial treatments, we have a pretty clear criteria of what it means to be evidence-based. In other fields, it's less possible to do RCTs, and so you always kind of draw from whatever your field bar is for what evidence-based means. You can still apply these concepts if you don't have an evidence-based thing, but it would be much harder to make the case for funding. And then finally, we have a set of specific frameworks, which you guys are already knowledgeable about, methods and outcomes in our toolkit. And I'll try to give you a high-level overview of what those things are. Next slide. So just to kind of give you a flavor of the types of questions that we try to answer in implementation science, there are questions like, can clinicians implement evidence-based practices in their setting? Can they implement this way of measuring blood pressure, for example? Next slide. What supports do they need to be able to do that effectively? Next animation. And what are those types of contextual factors associated with, for example, measuring blood pressure in kids? So is there something about the people involved? Is there something about the clinics or the health systems, like leadership or culture and climate? So those are the types of things that we think about. It's a little bit different than a traditional effectiveness study. Next slide. So to kind of bring home the point about what implementation science is or isn't, I think this is a valuable heuristic kind of tool that my colleague Megan Lane Fall and I developed actually for our Intro to MSci course at Penn, because we kept having folks say, I feel like I kind of know what it is when I see it, but I don't know where my research question falls in the subway line of what implementation science is. And so this is certainly imperfect and kind of a dynamic visual, but we did publish it in the hopes that it could help others kind of do that process of walking through the stages. So the first thing you might do, next slide, it's going to be a star that you're going to follow on the subway. Thank you. Is think about what your practice of interest is. Is it antibiotic prescribing? Is it something related to kidney transplants? Is it, psychosocial treatment? Has that thing shown efficacy? Next slide. If the answer to that is no, next slide, then you're really doing efficacy research. And so I think, you really want to be thoughtful about designing for implementation here. And we've been making the argument that we would hope for implementation scientists to be included on interdisciplinary teams from very early. So like in thinking about what you're doing, Erica, and I think you may not be developing de novo, you may be adapting existing psychosocial treatments or principles. So you may not be in the efficacy space. But just for example, if you were developing an entirely new treatment for the cardiac setting for pediatric populations, we would say, okay, work with an implementation scientist or make sure that you're working with the stakeholders on the ground to make sure whatever you develop is actually usable. And I think for those of you, all of you are embedded health researchers, so you're all working with your health system. So it's kind of, the problem is solved in a way that it wasn't like 20 years ago when people were developing treatments absent of the context within which they were supposed to be deployed. But that's an example of, thinking about how to draw in implementation science principles, but you're doing efficacy research there, right? The red line is not implementation science. So let's say your question is, yes, it has shown efficacy. Then you would go to that next spot where the star disappeared and you'd ask your question, has the thing shown effectiveness? Now, traditionally, if the answer to that was no, next slide, you would just be doing traditional effectiveness research where you'd be, doing more externally valid work. You'd be working with real world populations, using the clinicians within that health system and looking at patient outcomes. Do kids get better when you kind of take the treatment to the place where it was supposed to be delivered, but you're still kind of, and you're just kind of focusing on the patient outcomes. That's traditional effectiveness research. That's actually not implementation science. The yellow line is not implementation science. But let's say, next slide, you do a hybrid trial where you do both the patient outcomes piece and you start to understand the implementation processes and or look at implementation outcomes. And we have 3 types of hybrid trials. Then you are doing implementation science. So in a type 1, you're really interested in the effectiveness outcomes, but you're starting to dabble in implementation. So you might look at whether or not a particular treatment improved kid outcomes, and then you might ask, what were barriers and facilitators to implementation? On the other side, type 3, you're all in on implementation and you just want to do a double check on the effectiveness side. So you might ask, really, what's the best way to implement this using like a comparative effectiveness design, testing different strategies. And primary outcome would be something implementation oriented like fidelity or penetration. But you also are going to look at, you know, some patient outcomes that you can extract from EHR or something like that, just to make sure. So those are the hybrid effectiveness trials. And then the one in the middle, the type 2, you're doing a fully powered implementation trial and a fully powered effectiveness trial. Those are the hardest. I feel like lately everyone keeps coming to me with a type 2 and I'm like, those are so hard to execute. But they're also allow you to answer questions of equally about effectiveness and implementation. So on the bottom, that bottom green line is kind of like the bread and butter of implementation science. So mixed method studies to understand the context, and I'll be giving you an example of some of those in a moment. And then using that information to design your implementation strategies and then testing them in comparative effectiveness trials. So our interventions are our implementation strategies, not the treatments or the things. You know, how you measure high BP or the evidence-based practice for trauma in a cardiac population, or the way you do a kidney transplant. It's really how you support people in deploying the thing. So let me pause there and see if you guys have any questions about that big picture overview.
I don't have any questions. I just wanted to say that I think that this figure is very helpful. So thanks for developing it. And I think it really, and I know it's probably not this kind of clear cut, but it's really helpful.
I'm glad to hear that. And it's never clear cut. Yeah.
Yeah, well, I guess I was just gonna, because it never feels clear cut. So can I just, let's pose an example that you have in pediatric practice. We have so many just kind of guidelines of care that come out from all kinds of places. Primarily they're consensus based. So they're existing in regular practice as they occur. And so meaning they're all done, but I guess there's still, it's not certain that they're truly efficacious yet. Like here's an example of if you, you know, like we're told that we need to follow up newborn babies every month. That's probably, you know, like to check their weights with, you know, with CF to make sure that they continue to grow. And I think that the question is that overuse? Is that underuse? Is that, you know, but we don't really know, but where does that fit in this subway line? But because everyone does it, for a lot of people do it, I should say, you know, like as a whole. And so.
Yeah, it's a good question. I mean, we kind of get, the green line picks up once there's either a consensus statement or evidence that we should be doing something. This question of like, should you be doing this thing that we think is evidence-based or not, kind of precedes this, if that makes sense. And that's why I think this is really hard when we start talking about it across disciplines, because each of us has kind of a different bar for what evidence means. But generally, just from like a grants personship perspective, and this might not be a satisfying answer, but this is the best way I can answer it. If you have like a consensus or an expert guideline statement that something should be done, then we're kind of ready to rock for implementation science related questions. Now, is that thing right? That's a different set of questions to be answered. And certainly a hybrid design would allow you to explore that. But the focus really, at once we're starting with on the green line, our focus is how do we get people to do this thing that we think is the right thing to do. It's really not in the kind of philosophical space, and I know you're not talking about it philosophically, but like, you know, that is kind of the preceding. Once, you know, what's the bar for evidence that we need to feel like now we want to get people to be doing it.
Hey, believe it or not, I have a question. It's Don Goldman listening.
Hi, Don.
Definitely. So here's a scenario which is very common in improvement. We have shown on a very limited basis that a certain approach to frontline driven value-based care works in 5 wards in Scotland. And now we want to determine whether or not we can scale that up and find out whether it works in different conditions and contexts. So that's along the pathway from innovation to scale up. And I've never been able to figure out where that research goes. We certainly can't, we're really interested in, can this thing work in different contexts, but we're not interested in a pure effectiveness trial for sure. And I don't think it's type 2 because it's much smaller state. It's an earlier place in trying to test the innovation.
I guess the way I would answer that, and my latest thinking about this is that, like, we're going to have this core set of strategies that we probably want to use to deploy that. And then based on the context, we're going to have different modular aspects that we need to kind of bring in to make it fit for that setting. So there might be just like a blueprint of an approach that would be like, address the context, engage in stakeholder buy-in, identify the strategies that that particular system or site wants to use to implement. And so the process is the same everywhere, but the specific strategies that they use, if you were taking this to scale up, might differ. Like, I've been thinking a lot about, I don't want to get too in the weeds, but like qualitative comparative approaches where you can kind of identify the sequences or the configurations of strategies that are needed to make something successful. Because once we start thinking about something like scale up across like a country or, you know, several health systems, it's not quite like, we don't quite have the end that we need to necessarily be doing, you know, testing implementation strategies and using regressions. What I'm really interested in understanding is like, what are the configurations of the strategies in each place to make it work? So I would still put it on the green line in the bottom, in the space between, in the space around testing implementation strategies, but the approaches I might take might not look like a, you know, an RCT where we'd have 30 clinics in the condition getting one set of strategies and 30 getting a different set of strategies. So that's kind of how I think about it. I don't know if I articulated that in a way that's clear.
No, that's good. I think this is a really common problem when most of improvement, as you know, is not doing stuff that's been proved in 6 RCTs. It's somebody has an innovative approach to providing better care, and they want to increase their confidence that this will work under different contexts and conditions. Right. And we never have the money, the time to really do effectiveness research. We're just, it's sort of Bayesian. We have a sense that this is likely to be a good thing, and we want to learn as we go, and we're mainly looking at context and conditions and implementation strategies. So I have a feeling that we often get held back in improvement because implementation scientists say, well, you've got to, first of all, prove that this is evidence-based.
Right.
And we can't. I mean, it's like, we can't wait that long. We don't have that kind of money. Right. So it's just a dilemma. I'm not saying this is actually really useful, but there's a lot of work and improvement that doesn't cleanly follow the tracks.
Absolutely. And I think one of the things that Megan and I have been thinking about are like, what are the additional lines that need to be added to this subway to kind of superimpose some of these other areas that are adjacent / intersecting, you know, because there's a lot of different disciplines that are doing, you know, adjacent work, and that this doesn't fully capture. This is an overly simplified reductionistic heuristic to help people kind of put their idea somewhere. But you know, I think, Dawn, it'd be awesome if we could build this out with, you know, with you, and Megan does improvement work as well, and thinking about where what the additional lines are that need to be on this visual.
Yeah, well, what we basically do is, now that I have to use implementation science language for a lot of federal grants from Corey or whatever, we fake it. We take preliminary data that really doesn't show either efficacy or effectiveness, but we pretend it's good. And then we put in a hybrid type 3 so that we can figure out what we need to do to expand it. So I think that whenever I'm faking something, I realize there's a gap.
Yes, yes.
Don't tell anybody.
I hear you. I will tell you another place that's really confusing is knowing which hybrid to use. It sounds really simple, but turns out it's highly complicated knowing, and people won't necessarily agree. So in the example I'll be showing you, I'm hoping to do a hybrid type 3. And one of the reviewers was like, no, this is a hybrid type 2. And I said, well, Jeff Curran says it could be a type 3, but that's like not a good enough rationale for, a reviewer, of course. But there's not consensus on a lot of things. So some of it is as done as how you frame it. But when you have to use strategy in that way, it does raise this kind of earmark of like, this isn't necessarily, we haven't quite figured that out. But I think that's the fun part. Like, yeah. I think
here's something that I don't want to, you got a lot to say, but I've sometimes compared this to the phases in clinical trials. So if you take remdesivir or you take a vaccine for COVID, we're now moving from phase 1, which is just safety, to phase 2, where you're actually beginning to collect a lot of data on efficacy, but you're not. You're saying we're going to find the best dosage regimen, blah blah blah. But basically, for you to develop data on whether this works. And I feel the same way about some innovations that we're kind of in phase 2 of a trial, but we're not really going to have enough data to really stand up there and say, hey, this is really effective.
Right.
Anyway, I'm going to shut up now and go back to hybrid.
Quickly say, I don't want to derail you, but I just want to say I love the diagram. It's fantastic. And it for someone who's been studying and writing about health services research for a while, this is one of the best pictorial representations of the kind of work that we do. And what I see is almost like, I don't know if this is the metro, like a regional rail, because from each of these termini, there are implications for future policy and programs that follow. So thanks for putting that together, and thanks for making it so clear.
Sure, yeah, I once gave this talk in a rural area, and they were like, subway line, and I was like, oh, I don't know what to call it now. That's how I think. I live in a city. But yes, my pleasure. All right, let's zoom through because I know we only have about half an hour left and I have some stuff I want to make sure to cover. Next slide. All right, let's talk a little bit about applications. And this is really greatest hits because of the time that we have together. But I want to share some work that I've been doing around increasing firearm safety promotion in pediatric primary care. This is a really important area because firearm injuries and mortalities, second leading cause of death in the US. Firearm injury and mortality is increasing in the US, and a big portion of those deaths are suicide deaths because firearms are highly lethal. So over 90% of firearm attempts, suicide attempts, result in death. I became very interested in how we might use primary care, pediatric primary care, as a place to engage in universal suicide prevention. And when I became interested in it due to personal reasons. We had a firearm suicide death in our family. And so I went to the literature and I wanted to identify an evidence-based practice for this. And it turned out that, in 2008, a pediatrician had done this large trial, Sherry Barkin, and identified, it was an effectiveness trial, a national effectiveness trial of this multi-component intervention called the safety check. And one part of it, just one small part of it, had a firearm component to it. And it included asking about guns in the house, brief counseling, and giving out free cable locks. So that's really the EBP, or the evidence-based practice here. So it's taking a bigger intervention that had shown effectiveness in pediatric primary care a while ago, isolating the component that was relevant to the question of interest for my particular research program, and then asking, how can we get, pediatricians, nurse practitioners, et cetera, to increase their use of firearm safety promotion in pediatric primary care. And so we wrote an R21, and the study protocol is here if you're interested, because I think it lays out that part of the implementation science subway where you're designing, understanding context and designing your implementation strategy. So it's like very stepwise, and I think sometimes that linear stepwise process helps people conceptualize how they might apply the concepts to their own work. But I'm going to be talking about gun safety, so I'll kind of keep coming back to that in the examples. Next slide. So in plain language, because we never use plain language in interventioning, next slide. Safe firearm, name this and work with stakeholders. That's our thing. That's what we're trying to get clinicians to do. Implementation strategies are the stuff that we do to try to help people and places do the thing. So next slide. Implementation strategies. Can you, yeah, thanks. Are the stuff that we do to try to help people, places do safe firearm. The main implementation outcomes are how well clinicians implement safe firearm. Next slide. And you can think about how you might translate your stuff into the plain language. I found that that really helps me kind of get a sense of where I am in my understanding of a particular project, like if someone comes to me and asks me questions. So there's some critical tools in thinking about this. If you want to just zoom through all of these, I think there's probably 5 clicks. Thank you. Partnership should be on the bottom, 1 more click. So the critical tools that you need at your disposal in thinking about doing this type of work are those frameworks that we talked about and that we'll continue to talk about, that Theda brought up and said, hey, what's going on here? So I'll try to hit on that a little. How to understand context, how to think about which strategies to use and what outcomes to measure, and then what designs. And I will say, increasingly, I see everyone doing hybrid designs. I'm not seeing a lot of just straight implementations outcomes anymore. So I think the hybrid designs are becoming even more important than they were previously. And then just to say, the partnership underlies all the work. And again, I know you all are embedded health services researchers as part of learning health systems. So I know you already know how important that is. But without it, none of this implementation science stuff works. Next slide. So how do you know which framework to use? There's 150 of them. How do you know even what they are? There's been some seminal various frameworks. You know, this is one of the points a lot of overwhelmed by saying, you know, here's my research question. How do I know what to use? Next slide. One of the things that I think is helpful for you to know is that there's common elements in those 150. So that essentially means that you're looking for a framework that meets your research program need. And I would really encourage you to talk to other colleagues who are doing implementation science work rather than trying to sift through the literature to decide what you want to use. But the first common element is that they're multi-phased. So this is an example, the EPIS framework, Exploration, Preparation, Implementation, Sustainment by Greg Ahrens and colleagues. The idea here is that implementation is not static, it's dynamic, and that it's recursive and nonlinear. And so, you know, during the implementation process, you might be going through several stages. And I think this maps onto this concept of, you know, learning health systems really nicely. Like a learning health system is never static and it's constantly changing in response to the input that's coming through. And so I think that's an area of kind of convergence, the multi kind of phase to thinking of innovation and improving. Common element is that they're multi-level. So multi-level essentially means ecological. So you're thinking about the clinicians and the individuals involved, the groups and the teams, the organization, the larger system and environment. And that's really important when we're doing our mixed methods contextual inquiry and thinking about targeting our implementation strategies at those contextual factors that might be barriers for our implementation efforts. And so I rarely see a study that only focuses on clinicians or only focuses on organizations. So I think it's important to think about multiple levels of change. That being said, I rarely see studies that do more than 2 levels. And it's highly complex doing mechanistic work cross-level. So if you're trying to look at mechanisms of change at the clinician and the organizational level, it just adds a lot of complexity and design considerations. So that's just something to think about. Next slide. This is by far my favorite paper if you're just going to read one on frameworks, because I like to just like categorize things, and it does a really nice job of just saying there's these 3 buckets of types of frameworks. The first are kinds of the process models, or the ones that walk you through various steps. So first, engage your stakeholders. Second, collaboratively decide what you want to implement. Third, that type of multi-step process. That's the first bucket. The second bucket, which is really the biggest bucket, are what we call kind of the kind of explanatory, but not really. I really just call them determinant frameworks, even though that's one bullet underneath there, because it's really all determinant frameworks is what we have. That's what we have the most of. And these are these kinds of heuristic frameworks that just list variables under the multi-levels that you might be thinking about that you should be considering in the implementation process, but they don't give you any guidance about the causal relationships between the various constructs that you have in the framework, which can be another added check. Which framework do you pick? Constructs do you pick? For example, the CFR has many beneath it. How do you decide, and how do you know which ones to measure? The evaluation frameworks, and those are the ones that give you a sense of what outcomes you want to measure. The hybrid designs as well, right? Because in a hybrid design, you're looking at effectiveness M's, and you need somewhere to draw from as you think about which implementation outcomes to look for, because usually we know what outcome we're interested in for our area of expertise. Next slide. This is just an example of a determinant framework. This is the CFR. You can see here I've mapped on, and this was before we renamed the intervention, that there's the intervention characteristics themselves. So what are the feature of the safety check? Remember, that's the intervention that was tested in the effectiveness trial. What are the outer setting factors, like things about the broader socio-political context, the inner setting, which has to do with the clinics that we're trying to implement in, the people involved, and then the implementation process. CFR, when in doubt, you can just use the CFR. I've never seen the CFR not work. It's very broad, which is part of the wonderful thing about it, but it also makes it hard to know how to apply. But the CFR I've used across diseases, settings. It's really quite full to your research question. Next slide. So in response to Theta's question, and I think also Katie had that question, there's lots of frameworks to choose from. You can use more than one. I usually always use at least 2, never more than 3. Consult with colleagues, I would say, and then the literature to figure out what makes sense. Next slide. Context matters. So I've already made that point. I won't belabor that. Next slide. So we spend a lot of time in IMSCI talking about barriers and facilitators or determinants. They're really the same thing. And so I'm just gonna call on Erica. Next slide. What are some things that make it hard or easy to implement psychosocial treatments in the cardiac setting?
Well, I think, the babies' kids are very sick. There are many competing demands. This may not always be the top priority. I think that folks are coming from different places as to how important they feel it actually is. I think some of the younger, newer physicians are kind of more excited about it, and maybe some of the more seasoned folks who have been around for a long time where this wasn't as much of a focus, maybe less so, although it's not always that clear cut. I could go on, but we also don't have a ton of data that it works in this population. So we tend to rely on information from the NICU or from oncology, primarily the NICU, I would say. I think there's always this feeling of our babies are different. This is different. How do we know that it really applies? So those are just some of them.
Yeah, that's great, Erica. Thank you. So looking at this kind of these bubbles, a lot of what I heard you talking about were the people involved and also potentially the intervention itself and how effective it was. And I'm sure we could do this exercise for each of you in terms of the various things that you're coming from. But understanding the barriers and facilitators is really important. And I'll tell you, because I work across a lot of disease areas and settings now, there really does seem to be some common barriers and facilitators, time, priority, leadership, and then there's some unique ones depending on your intervention of interest. So I'm starting to think a little differently about how we should assess barriers and facilitators if each time we're kind of learning similar things, but maybe for another time. Next slide. So when thinking about, yep, you can go to the next box. When thinking about barriers and facilitators for firearm safety promotion, we used the CFIR to guide our thinking. Next slide. And what we learned in the 5 domains within the CFIR: brevity. So we knew from doing qualitative interviews with 70 stakeholders that was a big lift, that we needed to have a short intervention. That at the outer setting, the firearm culture in the United States was really important for us to address, particularly in the regions in which we might be implementing. We'd done our pre-implementation work in Texas and Michigan, and we heard a lot about how important firearm culture was. At the clinic level, we heard about the importance of workflow integration and leadership endorsement. With the individuals involved, we heard about the importance of self-efficacy. Not all doctors felt comfortable talking about guns and cable locks. And so you can see that the context, it's okay, you can go to the next slide. The context is really important for understanding what set of implementation strategies we might deploy to implement our particular thing of interest. I think even if you're not doing, you don't want to do a hybrid design per se, or maybe you just want to do a type 1. I think context is kind of low-hanging fruit, and if you're doing work in a health system, I think that it's fairly easy to measure that context, and so and we have some good tools for it, so I definitely recommend that. Next slide. Any quick questions? I want to make sure we get through everything, but if there are any outstanding questions, I also want to answer them.
Renee, it's a quick question. Maybe you could end with it. I'd love it if you could talk a little bit about funding sources for this type of work. Do you add on implementation science as a kind of an aim in projects, or are there particular funders that are more amenable to this type of approach?
Sure. I'll just say that now so that I don't forget. It depends. NIH is very interested in all-in implementation science studies. Although certainly I have been a collaborator on studies that have it like an aim 3, kind of like a cost effectiveness aim, but like an implementation effectiveness aim as it is. So I think NIH, particularly NHLBI, NCI, and IMH are very interested in this work. PCORI's latest PFA around COVID explicitly calls for implementation science and hybrid designs. I don't think PCORI is as interested in necessarily large-scale testing of implementation strategies. I haven't seen that yet, although they certainly have a dissemination and implementation smaller pot of money and calls for mostly in the dissemination space. HRQ, those are all funding mechanisms that you can go for. But NIH has been, I'm primarily funded through NIH in terms of like the all-in, like I'm going to make implementation science the main focus.
Great, thanks.
So implementation strategies, I already said, there are interventions. They're the way that we get folks to use the thing that we're interested in. Next slide. This is the most nascent area of our science. This taxonomy developed by Byron Powell and colleagues, that's now been refined into the ERIC taxonomy, gives you an idea of the types of strategies that we use They fall broadly. I told you I like to categorize things into these 6 categories. There's hundreds of strategies that fall within each of these categories. But if you're interested in testing implementation strategies, Byron Powell's work is really the kind of beacon in the field and thinking about that. Next slide. These are the 2 papers I would suggest that you read to kind of help orient yourself to the various options with regard to implementation strategies. Interestingly, nudges don't really make it as much in there. Thinking about what Corinna said, we have a center grant from NIMH around behavioral economics and implementation science, and it's interesting. A lot of the IMPSI thinking hasn't really incorporated that literature, so we've been trying to do that. But that's a side note. Next slide. You might ask, okay, which implementation strategies should I use in my study? Because that's all I really care about. And the answer to that would be that we don't know yet. And I know that that's frustrating. And I think part of the reason why we have not seen robust effects is the way that people have tested and selected implementation strategies to date. But I think that this is where the field is growing, and it's the really exciting place to be thinking about doing work. Next slide. So the latest thinking has suggested the importance of being really thoughtful in how you select and tailor your implementation strategies. Next slide, there should be 3 boxes on this slide. You want to make sure that you're incorporating the context, like we were just talking about, but also behavioral theory. We have lots of theories of behavior change, so we should be incorporating that into our thinking about how to design our strategies. And then stakeholder preference. You all are embedded researchers. You know it's really important to think about what your stakeholders care about and like, and that's another big piece. So you kind of need these 3 inputs into the process of thinking about what implementation strategy might allow you to achieve your goals. Next slide. So in the study that I described about guns, the way that we designed our implementation strategies was, first we just did a quick survey to understand the acceptability and use of the 3 components of the safety check, which was our evidence-based practice that we renamed Safe Firearm, because we just wanted to know how people felt about the intervention and how often they were using it to justify whether or not we needed to implement at scale. Next slide. And then we did all those interviews that I mentioned, and we unearthed the CFER contextual barriers and facilitators that we should be attending to. Next slide. And we took that information, and this is taken right from a grant application that hopefully will be getting funded. We're waiting news from council, where we essentially said that we're taking the CFER and what we learned in the CFER, so the characteristics of the safe firearm or safety check, the motivation of the clinicians involved, and some of those inner and outer setting factors that we learned. And we're testing a nudge in the EHR for clinicians to do, and sorry, we thought it was going to be called gun safe, but user testing told us that safe firearm was better. So our intervention, or our thing, is safe firearm, and the strategies that we're testing are just a nudge in the EHR versus a nudge plus facilitation for the clinics that are implementing the intervention. And then you can see our implementation outcomes, which are fidelity, how, you know, whether or not the clinician does the steps of the intervention, reach, acceptability, and costs. And then this is a hybrid type 3, because we're also interested in looking at whether or not parents change their storage behavior, and also downstream suicide outcomes, which we are not powered to look at all. So that's exploratory. Next slide. So in terms of implementation strategies, we have taxonomies, we have some promising approaches for how to design them. Amy, implementation mapping is pretty hot right now. A paper just came out about how to do that process of inputting stakeholder feedback, context, and theory to design implementation strategies. There are other methods. I'm most familiar with implementation mapping, but the long and short of it is you gotta assess the context and with your stakeholders decide which approaches they might be using. And I think this goes back to Don's question, like Are we ever going to have a situation in which we just say, this is the way you implement? Or do we say, here's the functions of what you need to be able to implement? You pick which strategies you use, so pick the form. I think we're still kind of in this space of trying to explore that question. And I think sometimes we try to kind of apply a drug paradigm to the way that we answer questions around inherently socially complex processes. And so I think that creates a little bit of tension. But my hunch is that we're either going to have a process through which people select their own implementation strategies, or a core set of strategies that you always need, plus modular strategies based on what the intervention is and the setting. Next slide. These are just information about ways to evaluate your implementation studies. These are the top papers I would recommend. They give you a sense of what outcomes you could look at. So, you know, I would definitely look at those. Next slide. Thanks. And this gives you a sense for the R01 that I was just describing that's coming out of the R21, where we designed our implementation strategies. You know, we were interested in both implementation outcomes and patient outcomes. And that's what makes it a hybrid. And you can kind of see circled the outcomes we were interested in. Next slide. Next slide. So you guys were all really jazzed on hybrid designs. There's a few more things that should be on this slide. I direct you to these two papers if you're interested in reading more about design. The Hendricks-Brown paper covers basically any type of design you might apply, all the way to like from pre-post to the hybrid designs for dissemination and implementation. The hybrid designs are definitely the way forward, and I think that there's really no justification for not looking at effectiveness unless it's impossible. At this point, from like the NIMH perspective, like they don't want an implementation study that doesn't include patient outcomes. That message has come through pretty clear. So I do encourage you to think about these hybrid designs, particularly for those of you all who might be going to NIMH. And again, the type 1 is all about effectiveness with a little I implementation. The type 3 is the big I implementation, little e effectiveness, and the type 2 is the most complicated, expensive, and in the middle. Next slide. And you know, all the designs that you've learned about in health services research apply here. Next slide. Next slide. I just want to comment once more, there's a few other things that should be on the slide. Partnership is really the foundation of all of this work. You know, it would be a mistake to think about doing any of it without really strong partnerships with the health systems that you're working with. And these are the partners that have supported the work that I've been doing around firearm safety promotion. Next slide. Oh. Uh-oh. My go-to meeting is, okay, thank you. Yeah, let's just keep going to few. Yep, what's coming down the pike? So as you plan for all your awesome studies, de-implementation is really big right now. NHLBI is really interested, as is NCI, in how we get people to use less of things that are low value. Implementation strategy mechanisms. So how do our implementation strategies work? Really big emphasis, particularly for NIMH, but across the board. Doing this work globally, and then of course what you all are doing, marrying the concepts of implementation science and learning health systems. So thinking about how those converge. Next slide. Next slide. This is my slide for like, okay, you're doing a practical implementation. There should be 2 more boxes on it. So the main takeaway here is, whenever you're doing implementation science, make sure you understand the context. Don't assume it's a knowledge problem and that training is going to solve it. Engage your stakeholders and your frontline folks. You can draw from IMPSI, and there's never going to be a silver bullet. It's always going to be a multi-level, multi-pronged approach. Next slide. So what we want to avoid is this quote from Tom Insel, the former director of NIMH. He spent 13 years at NIMH, got lots of really cool papers published, cost $20 billion. I don't think we move the needle in outcomes that matter for people with psychiatric disorders. So that's why implementation science is relevant. Next slide. think it's relevant to us all because it allows us to move that needle and achieve impact, which is kind of how I started this talk. Next slide. Will you go one more? I just want to see what I have left. I think, yeah. So this is the last kind of substantive slide. This paper describes how IMPSI and learning health system concepts converge and diverge, and I know that's probably really relevant to your all's thinking. I see them as being highly adjacent, and in fact, I see the idea of the learning health system as kind of being the next frontier of how we think about things in IMPSI, where for a long time we've been thinking about, can we implement one EBP in one setting, when really implementation science is super dynamic and your setting is implementing lots of things. And we've been trying to apply some of the learning healthcare system concepts to implementation science and vice versa. So thinking about, okay, how do you implement a learning healthcare system? What are the mechanisms that need to be in place? And how do you really operationalize that, particularly in mental health, is something I've been spending some time thinking about. Next slide. So I think the last slide is just a thank you slide to my colleagues who have supported the various things represented here. Next slide, I think, is nothing. So I will pause here. There are 2 minutes left. Are there any questions or comments in the last 2 minutes? 1 minute.
You mentioned, Renad, that there are a lot of tools to measure context that have been developed. How would we locate those were we to want to do that?
So there's a couple of repositories. CIRC has a repository, the Society for Implementation Research. You have to be a member, but I can help if you want to email me, help you get what you need. GEM is another database. If you know what constructs you're looking for, it's fairly easy for me or somebody who's, in the field or just Googling to help you figure that out. I would say we have good constructs for leadership, for organizational readiness for change, culture and climate. So we have some good org measures. We have some decent measures for individual attitudes, self-efficacy. Knowledge always is tweaked for like your area, but there's an emerging toolkit, I think. And then of course we use qualitative methods for the things that we don't have quantitative measures for.
Thanks.
Is there a version of these slides that you're able to share with us just by chance? Just that you had a lot of really good references, like check this paper, that I didn't get to jot.
Yeah, you're gonna get the slide.
Awesome.
Yep, you're gonna get the slide. Anything
Great.
else? Cool.
Any other final questions for Renad? Okay, well, I think we easily could have held like a whole series on implementation science, but I really think providing us with all the kind of fundamentals of implementation science was really, really helpful. And yes, Chuck and everyone, we will be sharing the slides. So, and hopefully if others have questions, they can reach out to you, Renad, just as you're encouraging folks to kind of reach out to experts in the field rather than muddling through it ourselves. So thank you very much for joining us, Renad, and I'm glad that you're right here with us on campus so we can reach out to you at any time.
You know where to find me. It was so nice to meet all of you, and please feel free to reach out. I'd be happy to speak to any of you about this further.
Great. Thanks so much, everyone.
Thanks.
Thank you.
Bye.
Thank you.
Rita, do you want to stay on the line?